I welcome you to this webinar on COVID series. I'm Dr. Sunil Kumar, Additional Director of Trivandrum Institute of Palliative Sciences from Trivandrum, Kerala. I will be talking about management of pain and other symptoms in COVID-19. So the learning objectives of this session are: explain the common symptoms of COVID-19, describe the basic principles of pain management, explain the management of fever, secretions, and cough in connection with COVID-19. I request you to download the ebook from the following link, which will help you to go through these topics on COVID-19 in a better manner. I also request you to download PALLICOVID app, which will help you a good insight into the symptom control in general palliative care setting. So let's look at the common symptoms in COVID-19. Fever is the most common symptom, which occurs in about 83 to 99% of patients, followed by cough, which occurs in 59 to 82% of patients, followed by fatigue, anorexia, shortness of breath, sputum production, and myalgia. So these are the common symptoms in COVID-19. So first we will move on to myalgia. Myalgia, as we already told, it occurs in about 11 to 35% of patients. And this is the aches and pains occurs in muscles, but it can also occur in relation with ligaments, tendons, fascia, and soft tissue that connects muscles, bones, and organs. Myalgia can be localized to one group of muscles, or it can be diffuse if it involves multiple groups of muscles. And if it is due to injury or trauma, usually it is localized to one group of muscle. But if it is due to a generalized illness like viral infection, it may be diffuse. And there are many causes of myalgias, which includes overuse, tension, certain medications. So our treatment should be directed towards the cause of myalgia. But we have to also understand that myalgia can produce pain, which can be mild in some patients, moderate, or severe. So we have to give symptomatic treatment for the pain with analgesics as per the severity of the pain. So let's move on to a patient story for better understanding how to manage pain. So this is Mr. X, 65-year-old man who is found to be positive for COVID-19, and he was diagnosed with carcinoma of the lung with rig metastasis 3 months back. He is complaining of pain on front of chest, right side. He also complains of pain all over the body due to fever after the diagnosis of COVID. So how can we assess and manage his pain? So for assessing the pain of the patient, we have to get more details about pain. So how can we assess pain? So if you remember this mnemonic LDPQRSTI, it will be easy for pain assessment. Where L is the location of the pain, where exactly the pain is. Duration, since how long you have pain. And there will be many factors which can decrease or increase the pain. Usually analgesics or rest can reduce the pain, and movements or food intake or other problems like psychological, social, financial factors, all those can aggravate pain. So it is important to find out palliative and provocative factors. Next is quality. Patient describes pain as aching, stabbing, throbbing, burning, lightning. So these are some descriptors used by the patient to describe the pain. So it is important for us to find out the quality, because from this we can get a clue about the type of pain. Mainly there are two types of pain: nociceptive pain and neuropathic pain. Nociceptive pain is due to stimulation of nociceptors or free nerve endings. And neuropathic pain is due to a lesion or a disease affecting somatosensory nervous system. So usually the neuropathic pain, the people describe it as burning, lightning, pricking, etc. Nociceptive pain can again be divided into two types: somatic pain and visceral pain. Somatic pain is the nociceptive pain which occurs on the external parts of the body, that is skin, muscles, or bones. And visceral pain is the pain which occurs from inside the viscera, that is inside abdomen or chest. And we have to ask the patient whether the pain radiates from the original location to any other parts, which can also be important to detect the type of pain. Next is severity. Severity can be assessed by asking the patient how severe your pain is. This can be done by many methods. There are many types of scales used to rate the score of pain. And one of the commonest method is numerical pain rating scale, where patient is asked to rate his or her pain in a scale of 0 to 10, where 0 means no pain and 10 means worst imaginable pain. So this is important to select the group or group of analgesics. Temporal factors are time related factors. For example, when is the pain more? Is it during day or is it during night? When you take analgesics, how long it gives pain relief? When you have pain, how long it lasts? So all those time related factors come in temporal factors. And it is also important to find out the impact of pain on activities of daily living. If the pain is severe, the patient may not be able to wake up in the morning, unable to brush, unable to take a bath, may not be taking food, or even unable to go to office. And we have to also assess the impact on other aspects of suffering, like what are the social problems that is caused because of pain, psychological impact of pain, financial impact of pain, and spiritual impact of pain. So we have to assess the patient as a whole to find out the impact of pain. So once we find that patient has pain, then we can use WHO analgesic ladder to treat the pain. WHO analgesic ladder is a three-step analgesic ladder. The first step is used to treat mild pain, which includes non-opioids plus or minus adjuncts. The second step is to treat moderate pain, which includes opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjuncts. Third step is to treat severe pain, which includes opioids for moderate to severe pain, plus or minus non-opioids, and plus or minus adjuncts. Non-opioids include paracetamol and non-steroidal anti-inflammatory medications. Adjuncts are those medications whose primary indication is not pain relief, but is helpful in some painful conditions. For example, tricyclic antidepressants, amitriptyline. It is used to treat depression, but it is helpful in neuropathic pain. So it becomes an adjunct. We have to also assess the psychological problems, social problems, financial problems, and spiritual problems of the patient. Because pain is not only an unpleasant sensation, but it is also an emotional experience. So we have to assess these domains of suffering because this is going to influence the pain. And we have to also support these problems. Otherwise, the pain treatment will be incomplete. So let's come back to our patient who was COVID positive and has carcinoma of the lung with rib metastasis, who is complaining of pain on chest. So if his pain is mild, we can use paracetamol as per WHO analgesic ladder. If it is moderate pain, second step of ladder can be used and tramadol can be used. If it is severe, third step of the WHO analgesic ladder has to be used and morphine is the drug of choice. And what is the role of adjuvants here? We discussed that pain can be divided into two types, nociceptive and neuropathic pain. So according to the type of the pain, we can decide whether we need an adjuvant or not. So if it is a neuropathic pain, adjuvants would be helpful, like tricyclic antidepressants or anti-epileptic. Let's move on to tramadol. Tramadol is an opioid which is used to treat mild to moderate pain. Tramadol has dual mechanism of action. It acts like any other opioid. That is, it acts on the opioid receptor. And it has another action like tricyclic antidepressant. So it inhibits the reuptake of noradrenaline and serotonin. Theoretically, oral tramadol is more potent compared to parenteral tramadol because after oral absorption, tramadol undergoes metabolism in the liver by an enzyme called cytochrome P2D6, and tramadol will be converted to O-desmethyl tramadol, which is more potent than parenteral. But for the practical purpose, both oral and parenteral tramadol are considered to be equally potent. Another thing which we have to remember about the tramadol is it can reduce the seizure threshold. So when we give tramadol to a patient who is prone to have seizures, like brain metastasis, we have to be careful. Or there are medications which can reduce the seizure threshold. So combining it with tramadol can sometimes precipitate a seizure. Tramadol can be started with a dose of 50 milligram 3 times or 4 times per day, and it can be increased up to 400 milligram per day. And even in chronic kidney disease, stage 5, 100 milligram per day can be used. Morphine is used to treat severe pain, and it is derived from a plant called Papaver somniferum or poppy plant, which you can see on the slide. Morphine acts on mu receptor to provide pain relief. And morphine can be administered through various routes. It can be administered orally, parenterally, intravenously, subcutaneously, epidural, and intrathecally. Sublingual administration is not usually advisable because it will take long time to administer and absorption through that route is also very less. Parenteral route can be used in those patients who are unable to take orally. And we don't have morphine suppositories in India. We use the immediate release tablet in a paste form to administer parenterally. There are various formulations of morphine available: tablets, capsules, injections, and syrup. There are two types of tablets or capsule. One is immediate release tablet and the other one is sustained release tablet. Let's look at the metabolism of morphine. So once morphine is swallowed, it goes into the gastrointestinal tract and it is absorbed from the upper small bowel. And after absorption, it goes into the portal vein, from where it goes to liver. And metabolism of morphine mainly takes place in liver. And the main metabolites produced are morphine 6-glucuronide and morphine 3-glucuronide. M6G and M3G in short. Morphine 6-glucuronide is the active metabolite which will give you pain relief, which is formed in less quantity, that is about 10 to 15%. Whereas M3G is produced in big quantity, like 45 to 60%. And after metabolism, these metabolites are liberated into the systemic circulation. After metabolism and its action, morphine and its metabolites are excreted from the body by glomerular filtration. So if the patient has chronic kidney disease, morphine 6-glucuronide can accumulate and its half-life is prolonged. So it can produce toxicities, including delirium, myoclonic jerks, extreme drowsiness. So it is advisable not to use morphine in patients with severe renal failure if other opioids are available. So what are the other safe opioids in renal failure? Fentanyl and methadone are two opioids which are comparatively safe in renal failure. There are some important points which we have to remember about morphine. Even though the duration of action is 3 to 6 hours, morphine has to be administered every 4 hourly. So starting from 6 a.m., then 10 a.m., 2 p.m., 6 p.m., and 10 p.m. Usually at 10 p.m., double dose of morphine is given so that the 2 a.m. dose can be avoided. And we can also give morphine as and when needed. But we have to wait for at least 1 hour to administer the SOS dose. If you give morphine orally, it will take about 40 minutes to 1 hour to have its peak action. So that's why we have to wait for 1 hour. And if you give morphine intravenously, it will take about 5 to 15 minutes for its peak action. Now let's talk about the side effects of morphine and opioids in general. Adverse effects with normal therapeutic doses are known as side effects. Most common side effect is constipation, which occurs in about 95% of the patients. And there is no tolerance happens to this side effect. Next is nausea and vomiting, which occurs in about 1/3 of the patients. And this is due to multiple mechanisms. It is due to stimulation of chemoreceptor trigger zone. It also stimulates the vestibular apparatus, and partly because of inhibition of motility of the gastrointestinal tract. But this is self-limiting. Within 3 to 5 days, nausea and vomiting will be over. Sleepiness and tiredness also occurs in 1/3 of the patients, which is also self-limiting. Dry mouth, itching, and urinary hesitancy are the rare side effects of opioids. Now, what are toxic effects? Adverse effects occurring when we give the opioid more than the required dose are known as toxic effects. Usual symptoms and signs are delirium, myoclonic jerks, drowsiness, and pinpoint view. So next is how can we manage the side effects and toxic effects? If the patient has constipation, I'm restarting. Management of side effects and toxic effects. So as we discussed previously, opioids can produce constipation. So we have to give a stimulant laxative along with an opioid prescription. Usually the stimulant laxative like bisacodyl, senna or sodium pycosulfate are the laxatives to treat constipation. For the first 3 to 5 days in an opioid naive patient, we can give anti-emetics, either that acts on chemoreceptor triggers on, like D2 receptor antagonist, for example, metoclopramide, or 5-HT3 antagonist, ondansetron. We usually use metoclopramide 10 milligram 3 times daily for 3 to 5 days. We already told that nausea and vomiting is self-limiting. So after 3 to 5 days, metoclopramide is usually not needed. The patient has toxic effects, delirium, myoclonus, extreme drowsiness, then it is an indication to reduce the dose of opioids. Usually, we can reduce the dose by 30%. And if the delirium is distressing, then antipsychotics like haloperidol would be needed in a smaller dose, like 0.5 to 1.5 milligram. And it can be repeated if needed. Because COVID-19 occurs in cancer patients, and if they are already on pain medications, what can be done? Usually, no change is indicated in the opioid regime unless there are deterioration in organ functions like renal failure. And we have to also understand that increased temperature can increase the absorption of transdermal opioids. So we have to be careful if somebody is on transdermal fentanyl patch. So what is the role of non-steroidal anti-inflammatory medications in COVID-19? We know that there are some controversy on the use of NSAIDs in COVID-19 because of the anti-inflammatory effect, which can dampen down the immune system. So we need more evidence for use of NSAIDs in COVID-19. Even otherwise, we know that NSAIDs can have many side effects. It can produce gastritis, even if we use it for short time. And it can produce peptic ulcer, hemorrhage, or even perforation in long time use. It can produce renal failure even with short time or long time use. Some NSAIDs can produce bleeding, like aspirin. And if specific COX-2 inhibitors, like etoposide, it can produce more of thrombotic tendency and more myocardial infarction and stroke. NSAIDs can increase the blood pressure. It can precipitate congestive cardiac failure in patients with cardiovascular risk factors. So NSAIDs has many side effects. But if the patient is near end of life, and if NSAIDs are definitely indicated, then we can use non-steroidal anti-inflammatory medications. We are moving on to the next symptom, cough. Usually the cough is dry irritant in COVID-19, and we know that it occurs in about 50% of patients. Usually non-pharmacological management can be tried first. Warm saline gargle, ask the patient to quit smoking. Use of honey or ginger, which can give a soothing effect. Dextromethorphan is a medication which can be used to suppress cough. It is available as syrup or as lozenges. If the cough is refractory to these measures, then we can switch the patient to morphine. Usually a small dose is needed to treat refractory cough, 2.5 to 5 milligram of morphine every 6 hourly, and it can be increased depending on the severity of cough. Next is secretion. Secretions are more common towards end of life. And in COVID-19, we have to avoid suction as much as possible because it can produce aerosols and the person who is doing suction can get infected. Secretions can be managed non-pharmacologically by proper positioning the patient, either left lateral or in the right lateral position, which will help to drain the secretion by gravity. And if it is not responding to these non-pharmacological measures, we can use anti-secretory medications. Glycopyrrolate 200 to 400 microgram every 4 hourly, intravenously or subcutaneously. Or hyacinth butyl bromide, which will not cross blood-brain barrier in the dose of 20 to 40 milligram 4 hourly, intravenously or subcutaneously. Atropine ophthalmic solution is another useful agent which can be administered sublingually every 4 hourly, 1 to 2 drops. If the patient has more of thick secretions, or if this medication produces more thick secretion, then sometimes it can add on to the symptom burden like breathlessness. We will move on to fever in COVID-19. So fever is the most common symptom in COVID-19, and it usually occurs 5 days after exposure to the infection. And there are some controversies regarding the use of NSAIDs for treating fever in COVID-19. And NSAIDs like ibuprofen can dampen down the immune system, and this can lead on to slowing the recovery process. It is also said that COVID-19 interacts with an enzyme that regulates salt and water concentration in the blood and can contribute to pneumonia in some patients. And some literature say that ibuprofen can aggravate this problem. So this is the controversy regarding ibuprofen for the treatment of fever in COVID-19. But WHO says there is no proof to recommend against the use of ibuprofen in the treatment of fever, and they are waiting for more research to happen in this area to get a more clear guidelines. The NICE guidelines suggest to use paracetamol over NSAIDs for treatment of fever in COVID-19. And they also advise to take plenty of water to avoid dehydration, but not more than 2 liters per day. And the dose of paracetamol is 0.5 to 1 gram every 4 to 6 hourly, and the maximum daily dose is 4 gram per day. So paracetamol is the favored medication to treat fever in COVID-19. To summarize, we have to assess the pain of the patient, and please remember the mnemonic LDPQ-RSTI so that we can select the analgesic as per the severity and also depending on the type of the pain. Paracetamol is the favored medication to treat fever, and it can also be used as an analgesic in the dose of 0.5 to 1 gram every 4 to 6 hourly with a maximum dose of 4 gram per day. Even though opioids have many side effects, constipation is the commonest side effect, and we have to prescribe a stimulant laxative to treat constipation whenever we prescribe an opioid. For pain relief, morphine has to be administered every 4 hourly with SOS dose to have proper pain relief. Morphine is not only an analgesic, it can also be used to treat refractory cough, and breathlessness. Secretions can be treated either by postural drainage or by medications like glycopyrrolate, hyoscine bromide, or atropine eye drops. So these are some resources which will give you more information regarding symptom control in COVID-19. Thank you for watching this webinar, and I request you to kindly download this feedback link and give your opinion. Thank you.